Next question that's been posed, how is efficacy determined? I think we've largely covered this again, but to emphasize, efficacy is, I think, the best that someone can do. So we aim for seizure freedom, we aim for no or minimal side effects, certainly no significantly bothersome side effects. And the efficacy is determined by the patient. The patient comes in, I'm happy or I'm not happy. It's working well, it's not working well. Medicines only work about 2/3 of the time. 1/3 of people do not respond fully to medication. And the first drug, the success rate is about 45 to 50%. And I tell people right off the bat, if this drug doesn't work, I usually go like this. I've got a few more available up my sleeve that we can use. This may not work. It may bother you. We've got plenty of other medications to use. And the first drug only works a little under half the time. Ideally, even if it doesn't work, it'll make your seizure milder and less frequent, and then we can try something else, raise the dose. And I generally let them know what the plan will be, that we're going to start you on this dose. If it doesn't work, we can always go higher, but in an effort to minimize side effect, we'll start a lower dose first and go up. And I usually will only bump it up once and bump it up reasonably. If raising it a bit more doesn't work, I go to another drug. The last thing you want to do is play around with a drug, titrating it a little bit and trying 4 or 5 doses. Tony Marson in Liverpool in the UK published a nice, I take it back, that's the wrong reference. Martin Brodie in Glasgow in the UK published a nice study looking at initial dosing and raising doses, and he found that 80% of people respond to the first low dose, and raising doses you only by another 20% response rate. So 1 dose, try 1 more, and then I would give it up. If they're not responding, and I think once someone has failed to respond to 1 drug, and certainly if that person has failed to respond to 2, that person should be referred to an epilepsy center. And ideally, the epilepsy center will offer some added value diagnostically and therapeutically. And what I prefer to do is get people well controlled and then refer them back to their neurologist who referred them, or to the primary care doctor who referred them, because I think they're best taken care of in the community with people they know well, and they avoid paying large parking fees to see me and my other colleagues at university centers where the parking's expensive. But clearly, persistence of seizures. If early on you're wondering, is this really epilepsy? Maybe I'm thinking about psychogenic seizures. Refer early right away. Most epilepsy units, between 25 and 50% of the people referred in for uncontrolled seizures don't have epileptic seizures, they're having psychogenic attacks. And nothing makes me feel more foolish than having prescribed 2 or 3 medicines to somebody and then finally admitted for monitoring, and it turned out the seizures were not epileptic. Or I had misclassified the epilepsy and I'm using the wrong drug. So I think that's going to be an important thing to do. In that first visit with the neurologist, or this boy's first visit with me, I take a bit of time to explain what seizures are. I explain, in lay terms, the concept of hypersynchrony, of abnormal firing. We discuss potential aggravating factors. I also discuss lifestyle issues at length too, and kind of go over various activities that they might and might not do, and precautions they should take for various things. You'd be surprised how many times I've told people that I don't think you should be using a chainsaw, to which you say, I love using my chainsaw, I love cutting wood. Just common things. And I usually say something in order, think about it, if you're doing this and you would hurt yourself badly or die, you probably don't want to be doing that. But there's a limitation. I let people swim, but make sure there's a lifeguard and the buddy system. A lot of people like to ride bikes. If they can hold off for a while till we're sure they're controlled, that would be ideal. Certainly wear a helmet with bikes and the other usual things. And I think you have to let them know that ideally they'll be well controlled. Most people do well. And our goal is to let them live a normal life. I mean, what's the goal of therapy? To live as normal a life as possible.